Hello, Medicos. Good day to all of you. This is Dr. BK for you, and today I will be discussing about the small intestine, that is mainly the jejunum and the ileum. Then followed by that, I will also be discussing about the blood supply to this jejunum and ileum, that is the superior mesenteric artery. You all know that the small intestine starts from the duodenum. The duodenum we have actually discussed in the last class. That is the fixed part of the gut or the proximal part, starting point of the small intestine. Now, as a continuation of the duodenum, we will be discussing about the jejunum and ileum. We will have a short introduction about the small intestine, its basic characteristic features of the small intestine, and then followed by that external features, how you can differentiate the jejunum and ileum by gross examination. Then we will see the differences between the jejunum and the ileum, how to identify jejunum and ileum. Then Meckel's diverticulum. So this is a short topic, but which is very important on a clinical basis about the Meckel's diverticulum. So the clinical anatomy of the Meckel's diverticulum we will be discussing. Followed by that, we will actually discuss the origin, course, branches and distribution of the superior mesenteric artery, which is the artery to the midgut. Now, coming to the small intestine, the extent of the small intestine, it starts from the duodenum to the terminal part of the ileum, that is the ileocecal junction. But when we discuss about the coils of intestine, it starts from the duodenojejunal flexure to the ileocecal junction. From the duodenojejunal flexure to the ileocecal junction, it is the most mobile part. The coils of intestine are most mobile part because they are freely suspended from the body wall by this large fan-shaped fold of peritoneum, which is called as the mesentery. So, because it is suspended by the peritoneum, it is also an intraperitoneal organ. It is an intraperitoneal organ. The total length of the coils of the intestine is 6 meters or 20 feet in length. It is 6 meters or 20 feet in length, of which the proximal or the upper 2/5 is by the jejunum and the distal 3/5 is by the ileum. Proximal 2/5 is by the jejunum and the distal 3/5 is by the ileum. So, which means around 8 feet of the 20 feet, first 8 feet is actually contributed by the jejunum. The remaining 12 feet or the distal 3/5 is actually contributed by the ileum. So, it is mainly developed from the primitive midgut. So, the midgut derivatives are actually from the lower part of the second part of the duodenum, distal to the opening of the bile duct and the common pancreatic duct, ampulla of Vater. Below that, the remaining second, third and fourth part of the duodenum. Then the whole of the jejunum, ileum, cecum, appendix, ascending colon and right 2/3 of the transverse colon. So up to this It is actually a midgut derivative. The coils of jejunum is actually contained within the borders of the colon, that is 1, 2 and 3 and off in an inverted U shape. It is bordered by the ascending colon, transverse colon, descending colon and the sigmoid colon. So 3 and half sides. It is contained within this, but we cannot strictly tell it is contained within this. The coils are mobile, so naturally what happens is they move during the peristaltic movement, or sometimes they come to lie in front of the ascending colon, mostly on front of the ascending colon, that is towards the right side. So mainly absorption, digestion as well as mainly absorption of the digested material takes place in the coils of jejunum and ileum. Now, when you look at the basic structure of the whole of the GIT, mainly it actually consists of the 4 layers. So from inside to outside, what we see is the mucosa. So the mucosal layer, and the mucosa consists of the lining epithelium. Then external to the mucosa, what you see is the submucosa. Okay, so the mucosa, these epithelial cells are actually resting on a membrane which is called as the lamina propria. Then external to that mucosa, we see the submucosa. So the submucosa has got mainly nerves, vessels, lymphatics, reticular fibers, and submucosal glands are present, not in all parts of the GIT or intestine. Now, for example, in the duodenum we have submucosal glands which is actually called as the Brunner's glands. Then the mucosa, between the mucosa and submucosa, you also have something called as the muscularis mucosa. Next to the submucosa, you see the muscularis externa, which is actually divided into the inner circular layer and outer longitudinal layer. Now, between these two only you have the Mesenter's plexus. They actually serve as the ganglionic fibers of the parasympathetic system. Next to the muscularis externa is the serosa, which is mainly formed by the visceral peritoneum. So mucosa, submucosa, muscularis externa, and the outermost covering is the serosa. Now this is the basic pattern of the gastrointestinal tract, right, starting from your pharynx or followed by esophagus up to the anal canal. Now, with respect to the small intestine, there are certain modifications which we come across. So now we will concentrate on the jejunum and ileum. What are the specific features of these layers with respect to the jejunum and ileum? The mucosa shows folds, permanent mucus folds, which is actually called as the valves of Kerckring. So these mucosal folds, what happens is they are permanent. What I mean is, even when the gut tube or your coils of jejunum or ileum, when they are distended or stretched, these folds, they do not disappear. They are called as the permanent mucosal folds. Now, if you look at the mucosa folds, then they show finger-like projections. So, the finger-like projections are actually called as the villi. So, these finger-like projections, what you see here, is actually called as the villi. And these villi differs in jejunum and ileum. For example, in the jejunum, they are leaf-shaped with a broad base, whereas in case of the ileum, they are actually finger-shaped villi. Now, this villi will be lined by the epithelium, which is actually the simple columnar epithelium. On top of this epithelium, again you see, which is not shown here, is the fine process, hair-like process, which is actually called as the microvilli. So you are able to see one villi which is lined by your epithelium, that is the simple columnar epithelium. At the top of the epithelium you will see microvilli or brush border. So first of all, valves of the Kerkring increase the surface area. Then again these villi, they increase the surface area again. Then on top of these villi, you see this microvilli. So they are all responsible for increasing the surface area of for absorption. So as the bolus of the digested material, they pass through it. So whatever has to be absorbed, for that reason, this mucosa is thrown into folds. Then you have the villi, and then you have the microvilli. Then you also see intestinal glands, which are actually called as the crypts of Libercule. So the crypts of Libercule, they actually open into the base of the mucosa where they pour their secretions, which is called as crypts of Libercule. Then you also come across solitary lymphatic follicles or group of lymphatic follicles. In the jejunum, they are solitary lymphatic follicles. In the ileum, they actually are present as group, which is actually called as the Peyer's patches. So here you are able to see the mucosal folds. These folds are actually called as the valves of Kerkring. So these folds are resting on the lamina propria. The resting membrane of the epithelium is actually called as the lamina propria. So what is actually projecting into the lamina propria is the lymphatic follicles. As I told you, they might be solitary or aggregated lymphatic follicles, which is called as Peyer's patches. So they produce lymphocytes and as well as plasma cells, mainly responsible for fighting any microbial invasions. So they are mainly for immune purpose. So deep to the mucosa of the submucosa, as I told you, mainly consists of the vessels, blood vessels, lymphatics. So from the blood vessels, what enters into the villi is the fine capillaries, and you also have the lacteals, which are the lymphatic vessels. So they absorb all the digested material, and from there these lacteals finally they will open into the venous system. To the portal vein, they are transported to the liver where they are detoxified. So submucosa contains blood vessels, lymphatic vessels, nerve plexus, that is the base nerve plexus. They are post-ganglionic parasympathetic fibers which is present between the mucosa and the submucosa. You have one more plexus which is actually called as the Mesenteric plexus between the two layers of the muscularis externa, inner circular and outer longitudinal. So they are actually called as the Mesenteric plexus or the Auerbach's plexus. Okay, so these are mainly responsible for motility of the gut. The mucosa also has something called as the muscularis mucosa. This muscularis mucosa again regulates the movement of the villi, side to side movement of the villi they can regulate. So basically it is mucosa, submucosa, then you have the muscularis externa, and finally the serosa, as I told you, which is formed by the visceral peritoneum. So this peritoneum forms a covering around the gut tube, which is the serosal layer. That is the basic structure of the coils of the small intestine, the jejunum and the ileum. With respect to the blood supply, jejunum and ileum are mainly supplied by the jejunal and ileal branches of the superior mesenteric artery. You are able to see the main trunk of the superior mesenteric artery. So this artery is the artery of the midgut. It is the artery of the midgut. From the left side of this artery, you see numerous branches, they arise. They are actually called as the jejunal branches and the ileal branches. These branches, what happens, they actually anastomose, they divide, forming arterial arcades. You are able to see they are forming arches or arterial arcades. The arterial arcades, they are less numerous near the jejunum, more numerous near the ileum. And finally, what happens? Branches from these last arcades, they are called as the vasa recta. Straight vessels called the vasa recta. They supply alternatively the front and behind. Only one set of vasa recta you see the jejunum and the ileum. Whereas in case of the pancreas, in case of the duodenum, you can see the vasa recta two sets, anterior set as well as the posterior set of vasa recta you come across, mainly in the duodenum. Okay. So one set straight long vessels, they are actually called as the vasa recta. They are end arteries. They mainly supply the jejunal and ileal branches. They mainly supply the jejunum and the ileum. But the most distal part, the end or terminal part of the ileum, these branches to the ileum are from the ileocolic artery rather than the directly from the trunk of the superior mesenteric artery. So branches from ileocolic artery supply the most terminal part of the ileum. Veins, corresponding veins named branches according to the branches of the artery, they drain into the superior mesenteric vein. You are able to see the most proximal part, end part of the superior mesenteric vein, which is going to join with the splenic vein to form the portal vein. Lymphatics, mainly they drain into the superior mesenteric nodes. So they mainly drain into the superior mesenteric nodes. The lymphatics, they undergo a circular course. Nerve supply again is by the superior mesenteric plexus. So you are able to see the superior mesenteric plexus, which is situated around the superior mesenteric artery. Here you have celiac plexus, which is actually surrounding the celiac trunk. So the superior mesenteric plexus mainly receives the branches from the splanchnic nerves. The splanchnic nerves, they are preganglionic fibers. So this is the ganglion. So the fibers coming to these ganglion is actually called as the preganglionic fibers from the splanchnic nerves. So greater, lesser and least splanchnic nerves. So from these, what happens? Sympathetic plexus, the fibers travel around the branches of the superior mesenteric artery and then they pierce the gut, and what happens? They supply the gut wall. Parasympathetic. Okay. Parasympathetic is mainly by the vagus nerves, the two anterior and posterior vagal trunks, both of them. They also come and relay the plexus, and from there, what happens is the ganglion, postganglionic fibers, they start from the plexus and they go and supply the respective viscera, especially the jejunum and ileum in this case. Now the parasympathetic fibers, they also form a local plexus on the surface of the viscera. Okay. And in case of the gut, they also form plexus as the mesenteric plexus and the Mesenter's plexus, which we have seen within the various layers of the gut tube. Okay. Now coming to the mesentery, I am not going to discuss in detail because in the peritoneum class itself we have seen much and enough of the mesentery. So large fan-shaped fold of peritoneum, which is responsible for suspending the coils of the intestine. It extends from the duodenojejunal flexure to the ileocecal junction, that is the right sacroiliac joint. That is the extent of the mesentery. It has got two borders. Free border are also called as the anti-mesenteric border, which actually covers the coils of jejunum and ileum. So that forms the outermost layer also. The outermost layer or the serosa. The serosa is mainly formed with the visceral peritoneum, which is nothing but the mesentery which is covering this. Free border encloses the intestine, whereas the attached border You are able to see the attached border. As I told you, it extends mesentery attached border from the duodenojejunal flexure to the ileocecal junction or the right sacroiliac joint. This attached border crosses the third part of duodenum, abdominal aorta, inferior vena cava, your right ureter, and right gonadal vessels. So this is your left gonadal, same right gonadal vessels. So they cross. This is your ureter, which is coming from the kidney. So they cross all these structures. Structures crossed by the root of the mesentery, and they get attached to the ileocecal junction, corresponding to the right sacroiliac joint. So between the two layers, they mainly transmit the blood vessels, the branches of the superior mesenteric artery. Then lymphatics, nerves, and one more content is the fat. The variable amount of fat is present between the two layers of the mesentery, and ultimately the free border they enclose the coils of the jejunum. So the contents of mesentery, you can tell coils of the intestine, fat, blood vessels, lymphatics, and the nerves. Okay, so that is the attached border for you. Now, what is the difference between the jejunum and ileum? The wall, if you just palpate the wall of the jejunum and the ileum, the jejunal wall will be very thick due to the presence of the mucosal folds or the valves of Kerckering. The valves of Kerckering are absent in the first part of the duodenum, and in the ileum they are very thin folds, not thick folds, and they are widely set. So not very closely set folds like this, they are widely set. So if you touch or you hold the jejunum with the help of the two fingers, your index finger and the thumb, and you roll the wall of the jejunum, you can feel as if one more tube is present inside it. A tube within a tube, because these mucosal folds give an appearance as if one more tube is present inside. So that is one thing. By external appearance, you can differentiate or delineate between the jejunum and the ileum. Next, if you look at the tube appearance itself, it is somewhat red because of rich vascular supply. This is comparatively pale because of the vascularity is little bit low. Then the lumen is actually wide and empty, large. The caliber of the lumen is somewhat wider as compared to the lumen of the ileum, and it is empty. Okay, as the food passes, then most of the times it remains empty. Whereas the ileum is narrow and loaded because there is a junction between the ileocecal junction. So the terminal part of the ileum where the contents has to be regulated into the cecum. So it is loaded. Then if you carefully examine the mesentery, in the mesentery, if you see, these vasa recta are long and the arterial arcades, one or two arcades. But in the ileum, the arterial arcades are more, so they divide twice or thrice, 2 or 3 generations you can see, but here you can see 1 or 2 generations. The ultimate, the long straight arteries, the vasa recta, they are long vasa recta, but here you see the vasa recta, they are very short. They are not that much lengthy, very short vasa recta and more amount of vasa recta. Then, if you look at the fat content in the mesentery, in case of jejunum, the fat is actually limited to the root of the mesentery. Okay, so near to the root of the mesentery. So when you actually throw a beam of light into these arterial arcades, they appear translucent or transparent. Whereas here the fat content is more, so in between the arterial arcades, you throw a beam of light, it will be opaque. The light won't pass to the other side. So here you have translucent windows, here you have opaque windows, because the mesentery fat in the ileum is abundant as compared to the jejunum. So mainly what happens? So to summarize, The jejunum, the valves of Purkinje are more nearly or thickly set, populated. So the tube is more thicker as compared to the ileum. Then the width or the caliber of the tube itself is comparatively wider in case of the ileum, in case of the jejunum than the ileum. With respect to the mesentery, more amount of fat in the ileum. Then arterial arcades, one or two arcades in the jejunum and the vasa recta are long, but here short and numerous vasa recta in the ileum. So now we will be discussing about the Meckel's diverticulum. So this is actually not usually present. If at all it is present, it might also be asymptomatic. So we come to know its existence only if it is going to produce some symptoms. It is also called as the ileal diverticulum. So you are able to see an outgrowth from the ileum. So that is why it is actually called as the ileal diverticulum or Meckel's diverticulum. It is the persistent proximal part of vitalo-intestinal duct. So your midgut will communicate with the yolk sac. There will be first a large communication, and slowly the communication between the yolk sac and your midgut will reduce, forming a narrow channel which is called as the vitalo-intestinal duct. Then once the lateral folding of the embryo is completed and the midgut rotation, everything is over, the vitalo-intestinal duct completely obliterates and it is shut off from the yolk sac. Yolk sac itself, what happens? The large yolk sac becomes a smaller definitive yolk sac, and that also is completely obliterated. If at all any part of this duct is present, remains in the adult, that is called as the ileal diverticulum or Meckel's diverticulum. Now, it is present in 2% of the subjects or people. It is 2 feet away from the ileocecal junction. So, near the ileocecal junction, 2 feet away from it, you will see this. And it is 2 inches in length. Okay, so a 2 inches long diverticulum present in 2% of people and 2 feet away from the ileocecal junction is the Meckel's or the ileal diverticulum, and it is present on the anti-mesenteric border, free border. The other border, the mesentery, will be attached, but on the anti-mesenteric border, you can see this diverticulum. So, people having this, what happens? Might be asymptomatic, they might not feel any symptoms. Now, when actually symptoms come, so this is the ileal diverticulum which has been removed. So, has been operated, laparotomy has been done, the peritoneal cavity has opened, they have opened, and naturally you have to incise the ileal diverticulum, because if it is inflamed, it has the caliber of the ileum, it has got cells similar to the gastric mucosa, so it can secrete hydrochloric acid. So because of that, what happens is it might get ulcerated and inflamed, then it will produce pain and all those things. Second thing, what happens is sometimes pancreatic tissue might also be found inside this ileal diverticulum. Okay, so because of that, what happens is most commonly it might get inflamed, or else this diverticulum might represent in one of the following forms which we are seeing here. The whole of the duct between your anti-mesenteric border of the ileum and the umbilicus, the vitalo-intestinal duct might be reduced to a fibrous cord. It might be reduced to a fibrous cord, or it might be patent, so completely open. The duct is not at all reduced, so it is communicating with the lumen of the ileum and the umbilicus, forming a umbilico-intestinal fistula. Okay, intestinal fistula. So the contents of the ileum might also sometimes, what happens is, might be discharged into the umbilicus. Umbilico-intestinal fistula, because the vitalo-intestinal duct is patent throughout its course Fibrous cord I already told you. Then sometimes what happens, it may be encysted form, which means both the ends are actually reduced to a fibrous cord, but in between alone it is patent. That is called a cystic type of the Meckel's diverticulum. Then the other type is the distal end alone is open. One end alone is open near the umbilicus. It is actually called as umbilical sinus. When both ends are open, it is communicating. It is a fistula. On one end, it is sinus. It might be a fibrous cord, or it might be completely patent, or it might be cystic form, or sometimes the diverticulum itself might be there, then followed by a fibrous cord. So these are the various types. Now, what happens is, because of this cord-like structure is present, the intestine sometimes might get wound around, might get rolled around this fibrous cord, and they might produce obstruction. Or the coils of intestine might get twisted around this, forming volvulus. Okay? Or sometimes intussusception, so internal herniation. A part of the gut tube might get herniated inside the other part of the gut tube, which is actually called as the intussusception. So all these are complications of the vitalo-intestinal duct or the Meckel's diverticulum if it is persistent. And the pain actually might mimic the appendicitis because it is almost present near to the appendicitis, near to the appendix. So the pain actually might mimic as if you are having appendicitis, the right iliac fossa. So with this, I have actually discussed about the small intestine, the jejunum and the ileum, its length, and how the coils of jejunum and ileum receives its blood supply, and the fold which is present inside in it, that is the mesentery, free border and the attached border, and then major differences, how to actually differentiate between the jejunum and the ileum. So, for example, in a laparotomy, if you are opening and then you see the coils of intestine as a whole, how to differentiate between jejunum and ileum is, jejunum mostly it will be empty, ileum will be loaded. Then if you actually palpate the wall, jejunal wall will be very thick. Then if you look at the mesentery, arterial arcades will be 2 or 3 in case of the jejunum and the area of jejunum, and we have long vasa recta. Ileum will have small numerous vasa recta and arterial arcades are more. Fat content in the mesentery will be more in the region of ileum. Now coming to the superior mesenteric artery, it is the ventral branch of aorta. The first ventral branch of aorta, what we have seen is the celiac trunk or the celiac axis. This is the second one, present at the level of L1 vertebra. It is present at the level of L1 vertebra, and usually it is between the splenic vein above and the renal vein below. Splenic vein and the left renal vein. So sometimes it might get sandwiched between these two structures. It is the principal artery of the midgut. So naturally it supplies your lower part of the duodenum, lower second part lower half. From there the whole of the duodenum, jejunum, ileum, cecum, appendix, ascending colon and right 2/3 of the transverse colon. All these are actually developed from the midgut. So the artery of the midgut is the superior mesenteric artery. Even during development, the gut rotation of midgut, which takes place 270 degrees anti-clockwise. The axis for rotation is also by this superior mesenteric artery. And developmentally, it is one of the vitelline arteries. Okay. So you have vitelline arteries, you have umbilical arteries. Umbilical arteries will be actually coming from the fetus to the placenta. Umbilical vein from the placenta, it goes towards the fetus through the liver. So umbilical arteries are mainly from the yolk sac. The vitelline arteries are mainly from the yolk sac. One of the vitelline arteries is your superior mesenteric artery. So that is the origin of superior mesenteric artery. It originates behind the pancreas at the level of L1 vertebra. So second ventral branch, the next ventral branch will be your inferior mesenteric artery from the aorta. So behind the pancreas, actually it originates. So the pancreas, this body of the pancreas has been removed so that we will be able to visualize the superior mesenteric artery. So lies behind the body of the pancreas, then anterior to the uncinate process. The uncinate process is actually behind the artery, which means the artery passes in front of the uncinate process and third part of the duodenum. So it also crosses anterior to the third part of the duodenum, then enters the two layers of the mesentery and passes within the two layers of the mesentery with a convexity towards the right side. With a convexity towards the right side, and ultimately it anastomoses with the ileocolic artery. With the ileocolic artery, which is a branch of the superior mesenteric artery itself. Okay, so it anastomoses with one of its own branch, that is the ileocolic artery, where it terminates in the right iliac fossa by anastomosing with the ileocolic artery. Throughout its course, I told you it maintains a convexity towards the right side. So in front of the third part of the duodenum, then it enters the two layers of the mesentery and it anastomoses with one of its own branch, that is the ileocolic artery. So towards the right side, the superior mesenteric vein is present. Okay. The superior mesenteric vein is actually present towards its right side. So near its origin, as I told you, it is between the renal vein, left renal vein below and the splenic vein above. So relations before entering the root of mesentery. It enters the root of mesentery after crossing the third part of the duodenum. Before that, anteriorly, as I told you, related to the pancreas and the splenic vein. Behind you have aorta, then you have the left renal vein, then the uncinate process will pass behind it and the third part of duodenum. So behind you see the aorta, duodenum, left renal vein. These are the relations, anterior and the posterior relations of the superior mesenteric artery. Then within the root of mesentery, so it crosses all the structures which is crossed by the root of mesentery. So that is your IVC, right ureter, right psoas major. So this is the psoas major muscle. Then this is your kidney from which the right ureter will originate. From the kidney you see the right ureter, right psoas major muscle. Then it will cross the inferior vena cava. So you are able to see the inferior vena cava. Okay. So all these are actually crossed by the superior mesenteric artery when it is going within the two layers of the mesentery. So same way, the same structures which are crossed by the root of mesentery, it is crossed by this one also. Only thing you have to exclude the abdominal aorta. So from the convex right side, actually from the convex right side, no, it is concave. Right side, it gives mainly branches. This is left side. From the convex left side, jejunal and ileal branches. These short branches are actually jejunal and ileal branches. Towards the right side, it gives the first branch will be inferior pancreatico-duodenal. Then it will give right colic, middle colic, and ileocolic arteries. So let us understand about these arteries one by one, these branches. So inferior pancreatico-duodenal artery, here you are able to see that is the from the right side first branch of the superior mesenteric artery. It is the first branch of superior mesenteric artery, and you are able to see it divides into anterior and posterior. See the groove between the head of the pancreas and the concavity of the duodenum. Between the head of the pancreas and the concavity of the duodenum, that is between the first, second and the third part, the artery divides into anterior and posterior branches. They anastomose with a superior mesenteric artery, which is a branch of gastroduodenal artery. They are anastomosed with the superior mesenteric, which is a branch of gastroduodenal. Thereby, they supply the head of the pancreas and also the adjoining part of the duodenum. So, first branch is the inferior pancreatico-duodenal artery. This one. Then, middle colic artery. So, this artery is actually the middle colic artery. It actually enters within the two layers of the transverse mesocolon. So, because it enters the two layers of transverse mesocolon, if at all you are going to explore or open the transverse mesocolon, it is always advisable to do it on the left side rather than the right side, because the artery enters, there is a chance of ligating or injuring this artery. Middle colic artery runs within the two layers of the transverse mesocolon and immediately it divides into the left and the right branch. It divides into the left and right branch. The right branch actually anastomoses with the ascending branch of the right colic artery. So, the right colic artery is ascending branch, anastomoses with the right branch of the middle colic artery. The left branch anastomoses with the ascending branch of the left colic artery. Okay. So, the middle colic left branch will anastomose with ascending branch of left colic artery. The right branch anastomoses with ascending branch of middle colic artery. So, three arteries: middle colic, right colic, left colic. Middle colic and the right colic are branches from the superior mesentery, whereas the left colic is a branch of inferior mesentery. Okay. The next artery, what we are able to see here is the right colic artery. This is your middle colic, which you have seen divides into the right and the left branch. The left branch anastomoses with the left colic artery. The right branch anastomoses with the ascending branch of the right colic artery. So, the right colic artery has an ascending and a descending branch. So, arises from the right side middle of the superior mesenteric artery, passes retroperitoneal and divides into ascending and descending. Ascending anastomoses with the descending branch of middle colic, descending anastomoses with ascending branch of ileocolic artery. Okay. So, descending branch of the right colic anastomoses with ileocolic artery, the ascending branch of ileocolic. So, thereby they are forming a continuous arcade or arterial arcade. The next artery, what you are able to see here is the ileocolic artery. So, passes downwards and to the right and divides into again ascending and descending branches. Ascending branch anastomoses with the descending branch of right colic. I will repeat: ascending branch of ileocolic anastomoses with the descending branch of ileocolic. Descending branch anastomoses directly with the superior mesenteric artery, terminal part of superior mesenteric artery. Okay. So, from the superior mesenteric artery, the descending branch. The descending branch also gives 4 sets of arteries to the cecum: anterior cecal arteries, posterior cecal arteries. The posterior cecal will also give appendicular artery: anterior cecal, posterior cecal, appendicular artery, and it also gives branches to the ileum. The terminal part of the ileum, as I told you, it is not from the jejunal and ileal branches, but they are branches from the ileocolic artery. Okay. So, ileocolic artery, descending branch anastomoses with the superior mesenteric artery. The descending branch also gives anterior cecal, posterior cecal, and the appendicular arteries. Ascending branch of ileocolic anastomoses with the descending branch of right colic artery. Okay. So, those are the branches of the ileocolic artery. So, we have seen all the branches on the right side. First one is the inferior mesenteric artery. Then we have seen the middle colic, right colic, ileocolic. Now, coming to the jejunal and ileal branches, this also we have actually described while dealing with the difference between the jejunum and ileum. So they are almost 12 to 15 in number, arranged from the left side of the superior mesenteric artery, from the convex side, left the convex side of the superior mesenteric artery, passes within the peritoneum, two layers of the peritoneum, and they anastomose with each other, forming arterial arcades. The jejunum and ileal branches anastomose, forming an arterial arcades. That is, they divide and redivide, forming 2 or 3 generations. One up to maximum 2 generations you are seeing in jejunum, but in the ileum you will see more than 2. Then from these arterial arcades you get straight vessels, which are actually called as the vasa recta. They are longer vasa recta and less numerous. The spacing between the vasa recta are more. They are end arteries. But in case of the ileum, the vasa recta are short, but they are numerous. More number of vasa recta, but they are short in nature in case of the ileum. So this is about the jejunal and the ileal branches of the superior mesenteric artery, which is the artery of the midgut. Mainly supplies the structures derived from the midgut. So finally I will repeat the branches once again. From the concave right side you have superior mesenteric, middle colic, right colic, ileocolic. Ileocolic gives anterior cecal, posterior cecal, appendicular arteries, and also gives ileal branches. From the convex left side you have jejunal and ileal branches. They form arterial arcades, and ultimately they give rise to vasa recta, long straight vessels in the jejunum. These straight vessels are shorter and more numerous in the ileum. Now coming to the superior mesenteric vein. So it is formed by the union of these small veins in the right iliac fossa. Okay, the ileocecal region they start. These veins unite to form the trunk of superior mesenteric vein, seen along with the superior mesenteric artery. To the right of the artery, the concavity of the artery, you can see the superior mesenteric vein. It terminates behind the neck of pancreas by uniting with the splenic vein. So it unites with the splenic vein and ultimately it forms the portal vein. Superior mesenteric vein joins with the joins with the splenic vein to form the portal vein. The tributaries of the superior mesenteric vein, corresponding branches of the arteries like ileocolic vein, right colic vein, middle colic vein. Okay, and occasionally it might also receive right gastroepiploic vein. So apart from the corresponding branches of the superior mesenteric artery, it also receives right gastroepiploic vein. So that is about the superior mesenteric vein. Okay. Then inferior pancreaticoduodenal vein, of course, this is corresponding to the branch of the superior mesenteric artery. So that is about the jejunum ileum and the superior mesenteric artery. Thank you very much for your patient listening.